Hello everyone, good morning. I am Dr. Jessica Geller and it's my pleasure to introduce our second session today. We're grateful to be joined by Dr. Victoria Sates, Dr. Greta Duncan-Wiebe and Dr. Amy Beathy. The first speaker today, Dr. Victoria Sates, is a clinical assistant professor of anesthesiology at the Children's Hospital Los Angeles and the Keck School of Medicine of the University of Southern California. She completed a residency in anesthesiology at the Hospital of the University of Pennsylvania and her fellowship in pediatric anesthesiology at the Children's Hospital Los Angeles. Her clinical interests include the perioperative management of adolescents undergoing bariatric surgery, facilitating the establishment of the bariatric surgery program at the Children's Hospital Los Angeles. Additionally, she serves as a question author for the American Board of Anesthesiology's certification examination. She will be speaking today on pediatric bariatric surgery, opportunities and challenges. Please join me in welcoming Dr. Sates.
Thank you for having me. Today I'll be talking about pediatric obesity and bariatric surgery. I have no disclosures, and the objectives are to describe the outpatient management of children and adolescents with obesity and identify medications of significance to anesthesia providers, to outline eligibility criteria for bariatric surgery in adolescents and discuss the different types of surgery, and to illustrate perioperative management of adolescents undergoing bariatric surgery. Since we're talking about obesity in children, we should define it. And for the purposes of the American Academy of Pediatrics, BMI is used. And we all know that BMI is not a perfect diagnostic tool to detect excess body fat, but since it's simple and inexpensive to perform, it's what we use. There are three classes of obesity that can be broken down based on BMI percentile for age and sex. In the red, you see those who have a BMI greater than 95th percentile and therefore are classified as obese. In the yellow, you see BMIs between the 85th and 95th percentile, and those can be classified as overweight. So the CDC tells us that in those 2 to 19 years old, the overall prevalence of obesity is about 20%. And this rate has almost quadrupled since the 1960s, whereby in 1963, only 5% of youth were obese. And on top of this 20% who are obese, we have an additional 16% who are overweight. So why is childhood obesity so prevalent? The causes are multifactorial, caused by genetic, environmental, and socioeconomic factors. We also know that there are pretty well-established trends in this country based on geography, race, and socioeconomic status. Specifically, the southernmost states have the highest rates of childhood obesity, whereas the northernmost states in the West and the Midwest have the lowest rates. Black and Hispanic communities have higher rates than white and Asian communities, and children who come from homes with lower household incomes are more likely to be obese than those who come from homes with higher household incomes. The other thing that we know is that obese children grow up to be obese adults. 55% of obese children will be obese as adolescents, 80% of obese adolescents will grow up to be obese adults, and 70% of adults who are obese at the age of 30 will remain obese throughout their lifetime. But I do want to be clear that it's not about the number on the scale or the size of the body, it's about the obesity-related comorbidities that come about. These are some of the more common ones that we see in children and adolescents. I want to share with you a study from the New England Journal of Medicine that was published in 2016, and it looked at 2.3 million adolescents in the 1960s. And then it followed them into their 5th decade of life, and it found that those adolescents who had a BMI greater than the 95th percentile were 3.5 times more likely to die of a cardiovascular event by the time they were in their 50s. Specifically, they died of stroke, myocardial infarction, or sudden cardiac death. So knowing that obesity is such a widespread problem and has lifelong implications for morbidity and mortality, the American Academy of Pediatrics revised their clinical practice guidelines on how to evaluate and treat children and adolescents with obesity in 2023. And this 100-page document is meant to provide guidance to primary care doctors and pediatricians on how to diagnose obesity, screen for comorbidities, and offer treatment in the outpatient setting. Some of the highlights of the guidelines are that we must recognize obesity as a chronic disease in and of itself. similar to how we recognize hypertension, diabetes, and cancer as a chronic disease. Therefore, watchful waiting is not appropriate. Also, we must address its multifactorial etiology by looking at its genetic, environmental, and socioeconomic factors. Then, all obese children should be screened on a yearly basis for comorbidities. Specifically, they should be screened for hypertension, dyslipidemia, abnormal glucose metabolism, and liver dysfunction. And then, comprehensive and concurrent treatment should be offered to these children based on the severity of their obesity. And this makes sense because if you have someone with class 3 obesity and 4 obesity-related comorbidities, they should be offered a very different treatment plan than someone who has class 1 obesity and no comorbidities. And finally, the overall goal is weight loss and remission of comorbidities. So what does comprehensive and concurrent obesity treatment entail according to the American Academy of Pediatrics? Well, there are 3 cornerstones. The first is intensive health, behavior, and lifestyle treatment, which is essentially modification of diet and exercise. But what we see is that when this is used alone, weight loss is 2 to 5%. The second cornerstone is pharmacotherapy, and we have oral and injectable agents available to us, and the weight loss varies between 2 and 20% depending on the agent used. And then finally, the third cornerstone is bariatric surgery. And the AAP says that surgery should be offered to those who are greater than 12 years old with class 2 obesity and 1 or more obesity-related comorbidities, or class 3 obesity. And most of the time, we see a weight loss between 25 and 30% in adolescents having surgery. So now I'd like to go through the 3 cornerstones in a little bit more detail. The first being intensive health, behavior, and lifestyle treatment, which is meant to be face-to-face, family-based, multidisciplinary counseling on nutrition and physical activity. And ideally, this should take place over several months with 75 contact hours. But we all know that we live busy lives, and this is not possible for most of us. So the AAP recognizes that and says just do the best you can. Reduce your sugar-sweetened beverages, engage in physical activity, and eat a balanced diet. But there are multiple papers that show us that even when done well, the weight loss is 2 to 5%. So if you have someone who has class 3 obesity and needs to lose 40% of their body weight in order to have risk reduction of comorbidities, 2 to 5% is just a drop in the bucket. The second cornerstone of comprehensive and concurrent obesity treatment is pharmacotherapy. And the goal is to find medications that not only promote weight loss, but also treat one's comorbid condition and obesity phenotype. And you can see that GLP-1 agonists are ideal for those who have insulin resistance, type 2 diabetes, and non-alcoholic fatty liver disease. Lisdexamfetamine promotes weight loss and is FDA approved for those who have binge eating disorder. And topiramate is commonly used for those who have binge eating disorder and cannot control cravings, although it is used off-label. And then bupropion and naltrexone is FDA approved for those who are 18 years of age and older and are ideal for those who have concomitant depression. So obesity phenotype is a combination of genetics and behaviors which leads to weight gain. And there are 4 recognized obesity phenotypes, the first being hungry brain, which refers to dysfunctional satiation. The second is hungry gut, which refers to dysfunctional postprandial satiety. The third is emotional hunger, which is eating in response to emotions. And the fourth is slow burn, which is dysfunctional energy expenditure. So ideally, we would find 1 or more medications that promote weight loss, treat one's comorbid condition, and addresses one obesity's phenotype. But we all know that we don't live in the real world, and so oftentimes the medications that are chosen are based on cost, side effect profile, and efficacy. And in general, the oral agents are significantly cheaper, but also less effective. And the injectable agents are more expensive, but also much more effective. So now I'd like to go through 2 pharmacotherapy agents that have implications to us as anesthesiologists. The first are GLP-1 agonists, which works to stimulate postprandial insulin secretion, reduce glucagon secretion, reduce hunger, increase satiety, and something that's important to anesthesiologists, delay gastric emptying. There are quite a few side effects, but by far the most common are GI symptoms, specifically nausea, vomiting, and diarrhea, and 50% of adolescents who are on this medication experience these side effects. But oftentimes they can be mitigated by Zofran and diet modification on the day of injection and the 72 hours after injection. The cost is quite high, unless covered by insurance, but the reduction in BMI percent is up to 20%. So without question, GLP-1 agonists are the most effective pharmacotherapy for the treatment of obesity in adolescents, and they work for the most adolescents, meaning they have the least heterogeneity in response. Specific considerations to anesthesiologists is that because they delay gastric emptying, the American Society of Anesthesiologists published clinical practice guidelines on how to manage them perioperatively. Also, if the medication is used to treat type 2 diabetes and it is electively held prior to surgery, we may have perioperative hyperglycemia. And then finally, titration of the medication mitigates its GI side effects. So most of the time, patients undergo a titration over several weeks to months to reach their target dose. So if we hold the medication for a prolonged period of time, a couple weeks, they may have to go through the titration again in order to have bearable GI side effects. So there are daily preparations and weekly preparations of the GLP-1 agonists, and you can see that some are specifically FDA approved for obesity and some are approved for type 2 diabetes. Nevertheless, we use many of them that are approved for type 2 diabetes off-label for the treatment of obesity. So in June of 2023, the American Society of Anesthesiologists published consensus-based guidelines on how to manage these in the perioperative setting, given the concern for delayed gastric emptying. And what they say is essentially if you're on the daily preparation of the medication, to hold it the day of surgery, and if you're on the weekly preparation, to hold it a week prior to surgery. So do GLP-1 agonists work in adolescents? And this is a seminal trial that was published in the New England Journal of Medicine in 2022 that looked at the use of semaglutide in those 12 to 18 years old who had a BMI greater than the 95th percentile or a BMI greater than the 85th percentile with one or more comorbidities. And this was a double-blind, parallel group, randomized, placebo-controlled trial. And there are two important points from this manuscript. The first is that the percent change in BMI was 16%, which is incredible for an obesity-related pharmacotherapy. The second is that this weight loss occurred in 73% of participants, which is an incredible response rate for an obesity-related pharmacotherapy. The next medication I'd like to talk about is phentermine. So you may have heard of phentermine from the fen-phen era of the 1990s. And specifically, fen-phen referred to the combination medication of fenfluramine and phentermine. So fenfluramine was ultimately withdrawn from the US market in 1997 due to its association with valvular heart disease. Specifically, they had thickening of the valvular leaflets and chordae tendineae. Nevertheless, phentermine has persisted and it is FDA approved for the treatment of obesity in those 16 years of age and older. It works by increasing energy expenditure and causing appetite suppression, by increasing the release of catecholamines in the hypothalamus, specifically norepinephrine, serotonin, and dopamine. Not surprisingly, the side effects are anxiety, tremors, and insomnia, and for this reason, the medication is dosed in the morning. It is quite inexpensive, even when not covered by insurance, because there is a generic available. And the reduction in percent BMI is 4 to 8%, which is actually quite decent for an oral agent. Many of the other oral agents only get 2 to 5%. And then specific considerations to anesthesiologists are that because you have depletion of the catecholamine stores, there are reports of hypotension on induction of anesthesia requiring vasopressor therapy. And for this reason, it's recommended to hold the medication 5 to 7 days prior to surgery. And where they get 5 days is essentially the half-life of phentermine is about 20 hours. So if you hold it 5 days, you're about 5 half-lives out. Nevertheless, if you have a patient on phentermine and you do see hypotension during anesthesia, I would reach for a direct-acting agent like phenylephrine, epinephrine, or vasopressin, and avoid the indirect-acting agents like ephedrine. So the third cornerstone of comprehensive and concurrent obesity treatment is bariatric surgery. And the American Academy of Pediatrics is pretty clear on who qualifies for bariatric surgery. You have to have class 2 obesity and 1 or more obesity-related comorbidities, or class 3 obesity. And the thought process behind this is if you have to lose more than 25% of your weight in order to have risk reduction of your comorbidities, the only way to do this is with surgery. we learned that intensive health behavior and lifestyle treatment and pharmacotherapy cannot achieve 25% or more of weight loss. So there are a few types of bariatric surgery. The two more common ones are the Roux-en-Y gastric bypass and the sleeve gastrectomy, and there are important differences between the two of them. The Roux-en-Y gastric bypass has both a restrictive component and a malabsorptive component. The restrictive component is a smaller gastric pouch, and the malabsorptive component is the fact that the duodenum is bypassed. And because you have this malabsorptive component, there is a higher risk of nutritional deficiencies and dumping syndrome. The sleeve gastrectomy has only a restrictive component whereby 75% of one's stomach is excised. And because you don't have this malabsorptive component, there is a lower risk of nutritional deficiencies and dumping syndrome. Over the last 20 years, the trend has been to move away from the Roux-en-Y gastric bypass and towards the sleeve gastrectomy in both adults and adolescents because studies have shown that there is a higher risk of nutritional deficiencies, dumping syndrome, and surgical complication rate in the Roux-en-Y gastric bypass. And for most people, the weight loss between the two of them are similar. The one subset of a population who may benefit from the Roux-en-Y gastric bypass over the sleeve gastrectomy are those who are super morbidly obese and really have an extraordinary amount of weight to lose. The issue of nutritional deficiencies is particularly important in the adolescent population. The most common nutritional deficiencies are iron and vitamin B12, but we also see calcium, vitamin D, folate, thiamine, and zinc. And this is particularly important in adolescents as it relates to bone health. So the concern is that those who have bariatric surgery early in life may have nutritional deficiencies that may impact their bone health and skeletal maturity throughout their lifetime. So for this reason, the sleeve gastrectomy is preferred in adolescents, and 95% of bariatric surgery that's done in adolescents is the sleeve gastrectomy. So now I'd like to walk you through some of the preoperative, intraoperative, and postoperative considerations in someone having bariatric surgery. In regards to their preoperative evaluation, we like to see certain labs, medical visits, and studies. These labs are those that are recommended by the American Academy of Pediatrics to be performed on a yearly basis, regardless of whether one is considered for bariatric surgery or not. They see many medical providers before being scheduled for surgery, but the one that I want to point out in particular is the fact that they see a psychologist. And the psychologist seeks to determine readiness for surgery. Essentially, what they look for is that the patient has a good understanding of the surgery and what is required afterwards to lose weight, that they are highly motivated, and that they have a strong support system around them to be successful after surgery. In regards to studies, we obtain a sleep study, and if a patient has severe obstructive sleep apnea, they are referred to pulmonology, but if they have mild or moderate, they are not, because the thought process is that their OSA will resolve quite quickly after their surgery. The surgeons request that an upper GI be performed just to look for any anatomical abnormalities that may preclude them from having surgery. And then finally, we perform a cardiac risk assessment, which is essentially a series of about a dozen questions based on the American Academy of Pediatrics Youth Sudden Cardiac Risk Assessment Screening Tool. And if they answer positively to any of these questions, they're referred to cardiology, and then cardiology determines whether further workup with an echo, an EKG, or Holter are warranted. So if we have a patient scheduled for surgery, the things that we look for the morning of surgery are that their GLP-1 agonists and phentermine were held appropriately. We check a blood glucose if they are a type 2 diabetic. There is this concept of permissive perioperative hyperglycemia in these patients, which is essentially acknowledging the fact that if we are choosing to hold their GLP-1 agonist before surgery and they are reliant on that medication for management of their blood glucose, they may be hyperglycemic perioperatively. And patients whom their GLP-1 agonists are their sole agent to control their glucose, or in those who are incredibly reliant on the medication to control their glucose, our endocrinologist may prescribe a short course of insulin to be started before surgery. And then finally, in regards to postoperative nausea vomiting prophylaxis, we apply a scopolamine patch. Some institutions use a Prepotent, either in place of the scopolamine patch or in addition to the scopolamine patch, and then we use ondansetron and dexamethasone in the operating room. So venous thromboembolism leading to pulmonary embolism is the third highest cause of mortality in these patients 30 days after surgery. The other two being sepsis and a cardiovascular event. And so in order to prevent venous thromboembolism, we apply SCDs, we use subcutaneous Lovenox, and then we encourage early mobilization. In the operating room, many of us still perform a rapid sequence induction, even if their GLP-1 agonists were held appropriately, just because we worry about residual gastric contents, and they have an increased risk of GERD due to the increased intra-abdominal pressure causing relaxation of their lower esophageal sphincter. We also recognize that these patients may be a difficult mass ventilation and laryngoscopy, and on top of that, they have a much shorter time to oxygen desaturation due to their increased oxygen demand, decreased chest wall compliance, and ventilation perfusion mismatch. And that's why we use ample pre-oxygenation before induction, and we optimize positioning by using a ramp in order to secure the endotracheal tube as quickly as possible. During the surgery, ventilation should prevent atelectasis and avoid barotrauma, which is essentially higher PEEPs and lower tidal volumes. I do want to bring up the concept of medication dosing scalars in obese patients, and depending on the pharmacokinetics of the medication, we may need to use total body weight, ideal body weight, lean body weight, or adjusted body weight to dose the medication. So we know that our total body weight is our lean body weight and our adipose tissue. But in morbidly obese patients, their adipose tissue increases significantly more than their lean body weight. Nevertheless, lean body weight contributes most significantly to a medication's volume of distribution and clearance. However, there is this scalar of adjusted body weight, which accounts for the fact that some of the medication may be distributed to the adipose tissue. So it avoids underdosing if you're using ideal or lean body weight and overdosing if you're using total body weight. Finally, in regards to multimodal analgesia, we use acetaminophen, ketorolac, ketamine, and dexmedetomidine in the OR, and we also use short and long-acting opioids as needed. Postoperatively, if a patient was prescribed BiPAP or CPAP for their OSA, they are expected to use it. While they are receiving systemic opioids, they should be on a continuous pulse oximeter. And in regards to the venous thromboembolism prophylaxis, they are required to have early mobilization. We expect our patients to get up and walk around within 3 hours after surgery. I will say that there is no consensus regarding the optimal duration of chemical venous thromboembolism prophylaxis in these patients. In a lot of the adult centers, they send patients home with 1 or 2 week course of Lovenox. That is generally not the practice in adolescents, just because early mobilization is stressed, and also adolescents are less at risk for venous thromboembolism and pulmonary embolism than the adult patients having this surgery. So now the million-dollar question is, does bariatric surgery in adolescents result in weight loss and remission of comorbidities? And in order to answer that question, I have to introduce you to the Teen Labs Consortium, which is essentially a consortium of 5 centers which performs a large number of bariatric surgery in adolescents, and they have been pooling and analyzing their data since the early 2000s. And their goal is to facilitate clinical research in the field of adolescent bariatric surgery. And they have published many manuscripts based on their data, many of them in the New England Journal of Medicine. So the first paper that I'd like to mention comes from the New England Journal of Medicine in 2016, and it looked at weight loss and remission of comorbidities in adolescents 3 years after they had bariatric surgery. And what they found was that the weight change after 3 years was between 26 and 28%, which is on par with what we usually see between 25 and 30%. The other thing to note is that the weight loss between the sleeve and the Roux-en-Y gastric bypass were actually quite similar. You may notice, though, that the number of participants in this study favored the Roux-en-Y gastric bypass, and that sort of reflected the practice of the time, which was in the earlier 2000s, to perform more Roux-en-Y gastric bypasses over the sleeve gastrectomy. But now that we know that the sleeve gastrectomy is less risky and leads to similar weight loss, subsequent studies have many more participants who had the sleeve gastrectomy over the Roux-en-Y gastric bypass. Nevertheless, the weight loss is between 25 and 30% and similar between the two groups. And this is probably the most impactful slide of my presentation, and this looks at remission of comorbidities in adolescents 3 years after they had bariatric surgery. And you can see an incredible remission rate of type 2 diabetes, prediabetes, dyslipidemia, elevated blood pressure, and abnormal kidney function. The one that I want to point out in particular is type 2 diabetes. So 95% of those who had type 2 diabetes before surgery had complete remission 3 years after surgery. And anecdotally, what we see at our institution is most of these patients can be off all of their hyperglycemic medications with complete remission about 6 months after surgery. So now you're probably thinking, why not wait until adulthood? Why are we rushing these 12, 13, 14-year-olds to surgery? Why can't we just wait a few years? And in order to answer that question, I'd like to share with you this manuscript from the New England Journal of Medicine published in 2019, and it looked at 5-year outcomes of a gastric bypass in adolescents compared with adults. And what they found is that 5 years after Roux-en-Y gastric bypass, the adolescents and the adults lost similar amounts of weight, 26 to 29% of their weight. Actually, the adults lost a little bit more weight. But more importantly, the remission rate of comorbidities was very different in adolescents versus adults 5 years after surgery. Specifically, in regards to type 2 diabetes, 86% of adolescents had remission of their type 2 diabetes, but only 53% of adults had remission. In regards to hypertension, 68% of adolescents had remission, but only 41% of adults had remission. So the question is there an age at which these comorbidities become less reversible? And do adolescents have a greater remission rate for comorbidities and a greater plasticity to reverse their comorbidities than adults do? So even though the adults may lose similar or more weight, the adolescents have a greater remission rate of their comorbidities. The other thing to note is that the teen labs will be publishing their 10-year data follow-up in adolescents having bariatric surgery in the very near future, within the next year. And so take-home messages are that comprehensive obesity treatment includes intensive health behavior lifestyle treatment, pharmacotherapy, and bariatric surgery, and that adolescents with class 2 obesity and 1 or more comorbidities or class 3 obesity should be offered bariatric surgery. In youth, weight loss after the Roux-en-Y gastric bypass and the sleeve gastrectomy are similar, about 25 to 30%, and that bariatric surgery in adolescents leads to remission of comorbidities. Thank you.
Thank you so much, Dr. Sates. We really, really appreciate that as a really good lens. Now we have the privilege to have Dr. Greta Duncan-Wiebe for our next speaker. Dr. Greta Duncan-Wiebe is a pediatric anesthesiologist who's practiced at Children's Nebraska for the past 14 years. She received her medical degree from University of Nebraska Medical Center in Omaha. She served her pediatric internship at Children's in Omaha and then completed her anesthesiology residency at Medical College of Wisconsin and her pediatric fellowship at Children's of Wisconsin. She is a mother of 4, wife, and enjoys running and traveling with her family. Please welcome Dr. Greta Duncan-Wiebe.
Good morning. Thanks, Jess. I'm happy to be here to speak with you about autism and neurodiversity. First of all, I have nothing to disclose. The learning objectives today that I'm going to address, I'm going to discuss the current diagnostic criteria for autism. Then I'll identify some common sensory sensitivities and management strategies for autistic patients. And then I'll discuss the importance of interdisciplinary care coordination for neurodiverse patients. First of all, what is neurodiversity? The concept of neurodiversity acknowledges that variations in brain function and behavior are natural aspects of human diversity, rather than deviations from a norm. Neurodivergent brains function, learn, and process information differently than those classified as neurotypical. Neurotypical people are then everyone else who is not neurodivergent. Under the umbrella of neurodiversity falls autism spectrum disorder, as well as any developmental language disorders, tic disorders, ADHD, dyslexia, and dyscalculia. The rest of my talk, though, is going to focus on autism, but many of the concepts that I'm discussing apply to all other types of neurodiversity. According to the DSM-5, autism is a multifactorial neurodevelopmental disorder. diagnosis relies on two main sources of information: the parents' or caregiver's description of their child's development and a professional's observation of the child's behavior. So the diagnostic criteria includes persistent deficits in each of 3 areas of social communication and interaction, plus at least 2 of 4 types of restricted repetitive behaviors. Persistent deficits in social communication and social interaction must appear across multiple contexts, including social-emotional reciprocity, ranging from abnormal social approaches and failure of normal back-and-forth conversations to reduced sharing of interests, emotions, or affect. They also have deficits in nonverbal communication behaviors used for social interaction, ranging from poorly integrated verbal and nonverbal communication to abnormalities in eye contact and body language, or deficits in understanding and use of gestures. They can also have a total lack of facial expression and nonverbal communication. And then they also have deficits in developing, maintaining, and understanding relationships. Trouble adjusting behavior to suit various social contexts. And difficulties in sharing imaginative play or making friends. And basically, these children often have no interest in interacting with their peers. And then, in addition to these criteria, they must have at least 2 of the 4 types of restricted repetitive behaviors, including stereotyped or repetitive movements. I think we can probably all picture children that have hand flapping or other repetitive behaviors. Or repetitive use of other objects, such as a fidget or speech patterns, lining up or flipping toys, echolalia, and idiosyncratic phrases that are repeated. These children often have insistence on sameness, inflexible adherence to routines, or ritualized patterns of verbal or nonverbal behavior. They can have extreme stress at small changes, difficulties with transitions, rigid thinking patterns, and they need to take the same route or eat the same food every day, wear similar clothes with similar textures. They also have highly restricted fixated interests that are abnormal in intensity or focus. And then they also have hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. And these symptoms must be present in the early developmental period. They might not become fully manifest until social demands exceed their limited capacities, and as children become older, they can learn strategies, and these patterns of behavior can become masked. Symptoms must cause clinically significant impairment in social, occupational, or other important areas of functioning. And then these disturbances must be not better explained by intellectual disability or global developmental delay. Intellectual disability and autism can frequently co-occur, but they are diagnosed separately. So why does this matter to an anesthesiologist? 1 in 36 8-year-olds are diagnosed with autism, or about 2.8% of children. These children then become adults and become part of the anesthetic practice of everyone in this room. Autistic patients are more likely to need general anesthesia for a variety of diagnostic studies, including MRI, GI procedures, dental procedures, and other healthcare maintenance. Autistic patients will also need other types of surgical procedures, like appendectomies, fracture repairs, and things other people need. So it's important that everyone has a framework for working with these patients successfully. There's an expanding body of published literature on this topic. These are just 3 papers from 3 different institutions across 2 countries, but they have common themes. Involving parents early prior to the arrival at the healthcare facility and communicating with them regarding the anesthetic plans increases success of the anesthetic. These papers also show that going with the flow on the day of the anesthetic results in better outcomes, less pre-medication, and greatly increased parental and provider satisfaction. These common themes are highlighted in the work that we are doing in Nebraska, which is what I'm going to talk about next. So this is just a picture of the hospital where Jessica and I both work, and Amy, who's speaking next. I became involved in a pilot program targeted at improving the perioperative experience for children and caregivers with autism. At the time, I was the medical director of our outpatient surgery center, and behavioral health made the determination to start this pilot program at the surgery center. This is a strategic decision due to the small footprint and very small nursing pool of nurses. So our program is called PATCH. This is an acronym that stands for Patient Assistance Team for Children's Hospital. While the program is led by members of the behavioral health team, it truly involves everyone who has contact with these children during their healthcare experience across all departments, and it has expanded to be used housewide. So briefly, the program begins with identification of patients with a diagnosis of autism. This is often done by the intake nurses during the pre-op phone call. Once a patient is identified as having autism or suspected autism, it triggers an alert for Child Life in our electronic health record. And then Child Life really takes it from there. They work with parents to create the adaptive care plan. And then this lives in the electronic health record and is visible to all caregivers. At our hospital, the members of the Child Life team really carry the bulk of the load in preparing the plan and also interacting with the families and patients. They serve as the point of first contact when these children are admitted to our hospital. The most recent addition to the PATCH program in the electronic health record is this blue banner that you can see at the top of the screen. This is visible across all users in our electronic health record, and it's a hyperlink that links out to the adaptive care plan, which I'll show you next. So this is what the format is of our adaptive care plan in our electronic health record. The information for this plan is gathered via an email or a structured interview by our Child Life personnel. The key elements of the adaptive care plan are, it discusses the communication, how the child prefers to be communicated with, how they experience receptive and expressive communication. It also identifies priorities. This is most often things that can be potential safety concerns. We find that many kids are in elopement risk, which is not surprising given they don't really want to be at the hospital for whatever their procedure is. And then sensory triggers are also highlighted. Sometimes children are very sensitive to touch. Often they don't want their blood pressure checked or any monitors on. Calming supports are identified. Other healthcare specific considerations are noted. Anytime we care for a PATCH patient, we see this PATCH plan secured to the door outside the pre-op room. It is really helpful for me personally, just knowing how the child likes a dress. Sometimes it's quiet and calm. Often the children don't want to be approached. It's better to speak with the parents, but it's good to know this at the outset before you go into the room. Additionally, our Child Life our Child Life workers intercept us prior to going into the room so that they can help us understand how to best speak with a child. So really the goal of the PATCH plan and all of our preparation for an autistic child is to prevent meltdown. This is a diagram which really just shows the stages of meltdown experienced by the child with autism. All of the measures that we have are put in place at an attempt of mitigating a meltdown. The stages of the meltdown, as you can see here, are the child begins calm and then something triggers them, which results in agitation. And then as the agitation accelerates, the child gets into a peak meltdown stage. And then they have to be de-escalated by the caregivers, and then they're in a recovery exhaustion phase. If we can be aware of and mitigate the triggers and modify the environment and use communication strategies appropriate for the child, and most importantly, just slow the pace, we can often prevent a meltdown. Some calming strategies that are useful include recognizing the signs of agitation at an early stage, speaking slowly and calmly, providing quiet recovery space for the child, and most importantly, using the parents as experts. They live with their children and know best what techniques have the highest chances of success. We often have patch patients in the management of sensory sensitivities that are unable to wear their bracelets or gowns. These are all measures that are taken in order to prevent meltdowns. Other things, we often have a play mat on the floor instead of a hospital bed, as that can be very stressful. The child life at our institution prepares the room with specific toys for these kids. If they prefer not having bright lights on, we have sunglasses and other measures that we can use. Frequently, these children show up at the hospital with a much shorter arrival time. Typically, where we have a 2-hour arrival time at our hospital, it's very common for them to show up 1 hour or less prior to their procedure. But the most important thing that I can't emphasize enough is to include the parents in the planning of the anesthetic. They're key into having a successful experience. So key considerations just to keep in mind: safety. Even though often these children start out small, they can become big. I recently took care of a 300-pound autistic child. And then just preparing the space and the staff that will be taking care of the patient. And really slow the pace and slow your speech, slow down your movement and activities. Allow time for the patient to process. So now I'm just going to go over a brief case study. This was a 15-year-old, 77-kilo male who was scheduled to undergo dental restoration under general anesthesia. This is a very common case. I'm sure everyone has taken care of this patient in the past. The adaptive care plan identified that he did not like liquid pain medicine, pre-medication. His parents told me that he has had IM ketamine in the past. That was a very traumatic experience for all of them, and they prefer not to do this again. One other additional useful piece of information was that the child has lab draws monthly for medication monitoring with no issues. But he would not tolerate an awake IV, but he could have lab draws. So using this information, I came up with a plan that the parents were in agreement with to use a butterfly needle, which is what they use to draw his labs. And instead of drawing labs, I would inject IV midazolam, and then we were able to go to the operating room calmly for a mask induction. While this may seem a little bit deceptive to the child, the parents were in agreement, and it provided for very nice pre-medication and induction conditions. So what difference has this program made? We've taken care of over 1,800 patients on the patch program at our hospital. 99% of scheduled procedures with adaptive care plans have been completed without significant behavior escalation. Early evidence shows a reduction in pre-meds. I think we've definitely seen a reduction in IM ketamine, which was kind of our standard for any patient that was autistic and larger. We've had a reduction in safety incidents, less call for security backup for restraints in the preoperative area and recovery. And we've had really positive feedback from parents, staff, and providers. Some of the parental feedback we've had: they took my advice, and even the doctor spoke to my son in a way that made the experience wonderful. The program started the moment we went back to the room. They took what I said about him into consideration and made it a more comfortable environment before and after his procedure. And this parent was really pleased with the way the whole staff interacted with their son. The parents really feel like they're being listened to by gathering this information on the front end. They have to explain less to us the day of the procedure. And they feel like an extra level of care was taken to make sure their patient felt as comfortable as possible.
Thank you so much, Dr. Duncan Wiebe. Our next speaker is Dr. Amy Beathy, who will be speaking on congenital heart disease for the general anesthesiologist. Dr. Amy Beathy is a pediatric cardiac anesthesiologist from Children's Nebraska in Omaha. After completing her anesthesia residency and pediatric anesthesia fellowship at the University of Nebraska Medical Center, she also completed a year of advanced training in peds cardiac anesthesia. She also serves as the Director of Clinical Operations at Children's Nebraska, where her area of focus emphasizes OR efficiency and faculty management. Please join me in welcoming Dr. Beathy.
Hello, and thank you for having me today. And thanks for the great introduction. I have no financial disclosures. So today, really we're going to be talking about pediatric congenital heart disease and how it affects a general anesthesiologist and into adulthood, and explain how the incidence of congenital heart disease is growing and demonstrate how this population is really changing to an adult disease. Review common cyanotic and acyanotic heart lesions to understand the history of these diseases and to help you understand what your patients really have gone through. Describe how anesthesia affects the physiology of congenital heart disease. Describe the progression of pulmonary hypertension and untreated congenital heart disease and the long-term implications of pulmonary hypertension on these patients. And finally, just to briefly go over the SBE prophylaxis indications. So how common is congenital heart disease? Common. So it's in 1% of all births are affected by congenital heart disease. 40,000 infants are born every year with congenital heart disease. 2 to 3 million individuals are thought to be living in the U.S. with congenital heart disease. And we're now seeing that there are actually more adults living with congenital heart disease than there are pediatrics. So when I went to residency not that long ago, I really didn't see very many of these adult patients, and I would say that is a vast difference to what our residents and fellows are seeing now. So 85% of babies with congenital heart disease are now reaching adulthood. And they're now living long enough to develop the adult illnesses. So I think a huge area of potential research and kind of unmined research is what these adult diseases do to these kids and how will they be affected by it and how should we manage them. Such as high blood pressure, obesity, acquired heart disease. In my pediatric practice, I don't really deal with coronary artery disease unless it's like a congenital anomaly. So it will be interesting to see how, as these patients live into their 40s, 50s, and hopefully even 60s soon, how these naturally occurring diseases affect these patients. So when I see a patient, there's really two questions that I ask and want to know right away. Is the patient pink or blue? And is the plumbing in series or in parallel? So that's really how I quantify a lot of my thinking, and just to simplify it down, because these patients' anatomy gets very, very complicated. So pink or blue, we obviously know cyanotic, acyanotic, but it's not just blue as in SATs of 70s. It's noting that a SAT of 96% on room air probably isn't normal for an 18-year-old. So if you see that in pre-op, understanding they are shunting somewhere, even if it's deemed an acyanotic lesion. And that then lends you into saying there's pressures somewhere that aren't right. So that's what I first ask myself. And then the second is the plumbing in parallel or in parallel or in series? So when you think about, go back to your physics class, they always taught us like the parallel was on this diagram is something that gives you that reminder. It's the same way in the heart. So when you have a patient with a normal heart, things are in series. It goes right atrium to right ventricle to the lungs, to the left atrium to the left. Everything's flowing in the nice right order. And that's the way we want it. That's the way it's physiologically supposed to be. In these kids and along their palliative course, a lot of times their plumbing will be in parallel, meaning their one working ventricle, whether that be the right ventricle, is doing the work to both circuits. So is that the right ventricle is pumping blood to both the pulmonary circulation as well as the systemic circulation, and how that is pumped is dependent on the PVR and the SVR. So once I know that if the plumbing's hooked up correctly and if they're blue or pink, then I just kind of move on to the next step. So what is the next step? So on the preoperative evaluation, so what surgeries have they had? And it is very important on these kids and these patients to understand their surgical history as well, to help understand what possible complications could not be on the problem list. So current cardiac anatomy, obviously recent echoes, looking at ventricular function, any sniff of pulmonary hypertension I try and sniff out of the chart, whether that is from previous cath or looking at the TR jet on the echo, if you can find that. And if, as well as the ventricular septum, is it flattened during diastole? Does it bow one way or the other? All of those things give you soft cues as to what's really going on with this patient. Valvular abnormalities are exceedingly common. Moderate is pretty good in congenital heart disease. These surgeons are tasked to piece these hearts together into a workable way to get them to the next palliation stage. So moderate is acceptable, but noted. Presence of shunts, so we'll go into that, and as well as how is the pulmonary blood flow supplied? Is it normal from the right ventricle, or is it through something like a BT shunt, which is typically from the right subclavian artery to the pulmonary artery? Baseline oxygen saturations are extremely important, maybe the vital sign I pay attention to the most in pre-op, as I was just saying. Presence of pacemakers, ICDs, those are in congenital heart disease. That's usually a result of a surgical, a side effect of a surgical or a complication of a surgical procedure. Usually a stitch goes through the pathway of the electrical pathway, necessitating the need of long-term pacers. Review of any recent heart cath data. Our heart cath doctors are really nice about putting pictures of what this patient's plumbing is in. They have a program that basically generates what the patient's heart looks like, because echoes are very hard to read, especially if you're not used to reading them. So it's very nice, and I encourage, if you don't have your cardiologist doing that, to encourage them to do that, just to make it clear for all providers, including bedside nursing, as well as physicians, APRNs, everybody taking care of this patient, that when a patient such as these come into the hospital, they have a picture of their heart plastered on in their room for every provider to see and understand. It makes it really nice and a lot easier to figure out. As well as labs, so hemoglobin. So if patient's chronically cyanotic, you'll see they should have a hemoglobin in the 15s, 16s, even 17s. If they don't, I would say they're anemic. If a baby comes in with a SAT of 80 and their hemoglobin's 12, that's not right. So I would question that and say why, and it definitely warrants further workup. Liver kidney function. So a lot of the times these kids, so if you think about a patient with Fontan physiology that we will be going through, their blood flow into the pulmonary circulation is passive. So it really relies on a lower PVR to allow that flow to go into the lungs. If those pressures go up, that flow does not go there and it naturally backs up. Well, where does all that blood back up into? The liver. So it naturally, you'll see liver disease in these patients, as well as kidney disease from chronic cyanosis. Electrolytes are frequently abnormal, but the majority of that is due to medication induced from medications like Lasix. And obviously, just like every patient, current symptoms are changed from baseline. So what can these patients do? Can they go, does the child play? Does the child, can the baby finish a meal without falling asleep? All of those normal questions that you would ask. Recent URIs, I will say I'm much more conservative with these patients with recent URIs than I am deemed with a normal physiological heart, especially if you're doing things where you're going to be going into the cath lab trying to measure pressures. Why would you ever do that on a kid who's just recently had a cold? That cold will naturally raise PVR, so there's no point in doing the procedure because they're not going to be accurate. So pink versus blue. So obviously the reason they're pink or blue is based on their plumbing. So pink blood contains enough oxygen, but is pumped abnormally throughout the body. So babies may not have an apparent symptom, but over time, the condition can continue to cause problems in health. These examples include VSD, ASD, where you have these shunts that cause a 2-to-1 from your pulmonary blood flow to your systemic blood flow. Those lungs are just flooded. You'll see increased vascular markings on chest X-ray. The baby will be grunting. They'll be very prone to respiratory tract infections. So that is very typical of these kids, but their stats will be normal. And they'll be normal up until a point where they're not normal anymore. So balanced AVSD, coarctation of the aorta, PDA, all the acyanotic congenital heart disease will be pink. So, but the blue lesions are due to how we've hooked up the plumbing. So again, tetralogy flow, transposition, pulmonary atresia, TAPVR, truncus arteriosus, hypoplastic left heart syndrome, as well as tricuspid valve abnormalities. So if you look at the acyanotic heart disease, so coarctation of the aorta, as we know, gets repaired in infancy. So what does that mean for the general anesthesiologist? Well, most of the time it doesn't really mean a lot. But one big complication that I didn't really appreciate until I got into peds cardiac is the rate of recurrent laryngeal nerve injury in these patients. So it's cited in the literature at about 4%, which what does that mean to you? Well, when you have a paralyzed diaphragm, it may mean that blocks aren't very safe as they get older. And so really, and it's not saying you need to have that diagnosis confirmed before you do a block, but making sure that that patient's respiratory status is having a higher index of suspicion that this patient's respiratory status is more at risk than somebody with not that history. And I'm sorry, that was with the PDA ligation. So when they ligate that PDA, the recurrent laryngeal nerve on that left side goes down and tucks underneath the aorta. And when they go in and repair that, it's obviously a very, very small baby. So seeing those nerves are next to impossible. It's really not a surgical. I don't blame surgeons for this because when you look inside these babies' hearts, it's truly astonishing that the rate is only 4%. So for PDA, that is a huge risk. Coarctation of the aorta, they're a very high percentage of re-stenosing. Oftentimes they will just do a bulk end-to-end anastomosis. Well, with any anastomosis, they can just stenose back down, and there's no real way to know that. ASD and VSD, these are the kids that keep me up at night. So we recently had a 3-year-old come in with an undiagnosed VSD, which is devastating because those lungs have seen high ventricular pressures for 3 years of the child's life, and you get pulmonary hypertension that may or may not be reversible. And you may not be able to close the VSD because if you close the VSD, that right heart is then forced to pump against pressures that really aren't conducive to life. So if you hear a murmur there in kids, I just say get the echo. It is not worth missing. ASDs take much longer to cause pulmonary hypertension because they don't have the ventricular pressure contributing to the elevation in pulmonary pressures. But if you hear a murmur when you're taking care of these kids, please just get the echo. Everyone, when people say, oh, it's a flow murmur, I don't really know what that means. That is what a murmur is flow. So if I hear it or it doesn't sound normal to me, just please get it, because the downside of not treating it early is just devastating. So atrioventricular canal defect, very common in Down syndrome babies. It's only acyanotic if it's balanced. So a lot of times the ventricle and the common AV valve is lined up perfectly so that the pulmonary blood flow goes to the pulmonary circuit. The left heart is pumping to the systemic circuit, and your sats are really normal. But typically what I would say is you don't see sats of 100%, you see sats of 95, because there's obviously in this lower right-hand picture, there's still significant mixing. So acyanotic, these patients, the biggest risk is that overcirculation that we talked about from the pulmonary blood flow. So prone to respiratory infections. It's really hard to decide when to operate on these kids, just because it's like what comes first, the heart disease causing the inability to mount a response to the pulmonary infections, or like when's to optimize surgery. It's a very tough call. But the long-term pulmonary hypertension is really the goal of, and the remodeling of the RA and the RV is what you're really trying to prevent. So cyanotic congenital heart disease is what is really the population that's really grown in the last 5 to 10 years, because we've just gotten better with treatments and medications to get these kids into adulthood and to keep them healthier longer. So so this top picture up here is tetralogy of flow. And so just a refresher for everyone. So you have the VSD, and then really you have the pulmonary circuit is then stenosed. So you have pulmonary stenosis, that overriding aorta, and the thickened RV muscle. So when that gets repaired, usually everything should be normal. When you guys are seeing that, what sometimes will happen, if they can't fix that pulmonary valve, you'll see a lot of RV to PA conduits, and that will, it's just not, it's not something people are used to seeing. So it will cause some questions, but honestly, there's really no difference in management between those RV to PA conduits and just a normal PA. So I would not treat anything different. Transposition of great arteries, the same thing. What the procedure that they will do is called an arterial switch, where they will literally just switch the aorta and the main pulmonary artery so that they are hooked up to the correct ventricle. Usually these kids do very well, and into the long term, you don't see a lot of complications from them. So the biggest question is, how often do you have to see your cardiologist? Is a great indicator of how sick their heart is, but they do very well. So down here, tricuspid atresia. So there is I was taught very early, wherever the lesion is, it's no flow, no growth. So wherever the lesion starts is then the subsequent structures behind that is what is affected. So in tricuspid atresia, the lesion or the insult is at the development of the tricuspid valve. So therefore you have a very atretic right ventricle, and oftentimes a very atretic main pulmonary artery. These patients will frequently come in with Glens or Fontans, because obviously we can't create a right ventricle. And we'll go through that, what that physiology is. TAPVR in the far right. So these are the patients, again, after they are repaired, they should really be normal to you when you see them. So what you have is an anomalous pulmonary vein that's going to the wrong place. So in this example, so it is going, you have an abnormal pulmonary vein that's, instead of draining into the left atrium, is draining into the right atrium. So there's an over circulation problem in this one. And as well as there's a massive mixing from usually an ASD. Where you can get really, really dangerous on this one is when it becomes obstructed. So if that abnormal pulmonary vein is infradiaphragmatic, it won't drain the pulmonary blood flow, so that it gets blacked up into the lungs, and there's really no way to get any type of pink blood into the systemic circuit. And then we have the truncus. So truncus is basically when during embryology, the main pulmonary artery and the aorta fail to septate, causing problems. Obviously, it's a in parallel circuit because it has one tube pumping to everything. So the single ventricle pathway. So we'll just use hypoplastic left heart because that's the most widely known throughout congenital heart disease. So you'll have a blue baby. So the lesion starts at the mitral valve, an atretic left ventricle, atretic aorta, and the baby's reliant on PDA or PGA immediately after birth to supplement pulmonary blood flow. SATs will typically be in the 70s to 80s. So unless you're doing peds cardiac, you really won't see these patients. Then what they will do at 1 to 2 days of birth, after 1 to 2 days of birth, is a Norwood procedure where there is an arch reconstruction. So you have to make your aorta much larger to, number one, feed the coronary arteries, and to number two, provide systemic blood flow. They will make sure the atrial septum is wide and there's no restriction of mixing. And the pulmonary blood flow will be through a Sano or a BT shunt. So the BT shunt is from the PA, from the subclavian artery to the PA, or the Sano is from the RV to the PA. There's no real difference in outcomes in those. It's more institutional preference as far as which one is done as far as the source of pulmonary blood flow. Then after, and the reason we do it that way is because the PVR in infancy is high enough that you need that ventricular push behind it, and you can't have pulmonary blood flow be passive at this stage. The Glen is done at about 3 to 6 months of age. So after that PVR goes down, we say, okay, now you can have a passive form of pulmonary blood flow. So the superior vena cava is attached to the main pulmonary artery, and the Sano and the BT shunt is taken down. This then, now everything is in series. So, but you still have significant mixing because the IVC is still flowing into your right ventricle. So the patient's SATs, while better than the Norwood, is still not normal. I would say SATs are usually between 80 and 90 at that point. And then finally, and what you guys will see in adulthood, you will have the Fontan. So eventually the patient becomes blue enough at the Glen, and this usually happens at around age 5 or 6, that the patient just can't keep up with activities of daily life. They are outgrowing their Glen, and their lower body is becoming much bigger than their upper body. And so they need to then take that IVC and attach it to the main PA. Occasionally what you'll see in your practice is a fenestration, and that is because so we'll always do heart caths on these patients before we do a procedure, a Fontan procedure. So if the patient is a borderline Fontan, meaning is that PVR a little on the iffy side of whether the blood will just naturally flow there, they will leave a natural fenestration into the right atrium, so there could be a pop-off. So blood won't back up into the liver, they won't, and cause liver complications. It will pop off into the right atrium at the expense of cyanosis. So QP to QS ratio It's the ratio of pulmonary blood flow to systemic blood flow. It's very important to know on these patients. So recent cath reports will frequently say it, but basically it's how protected are your lungs. Or so a lot of times like VSDs, it can be like a 5 to 6 to 1 shunt. So huge, these lungs are sick. When you see that number, even though the baby looks normal, that number tells you that that is a very abnormal number. We're not going to go through the calculation, but that is how they calculate it in the cath lab. But please note, normal is that in-series plumbing. So it's a 1-to-1 ratio. Anything deviant from 1 to 1.2 to 1 ratio is normal. So any deviation from that needs to be paid attention to. So, and we in my land, we do things to really manipulate the systemic blood flow by just changing things in anesthesia. So if I want to decrease SVR in anesthesia, what do? We make sure factors that decrease SVR, so adequate anesthesia, positive intrathoracic pressure, vasodilation from any cause. So if I am having one of these patients that I'm struggling with SVR, I'm really looking at those factors. Factors that increase my SVR, which again, in a Norwood patient where I'm really trying to balance those two circulations, I don't want a really high SVR because that means all my blood flow is going to the systemic circuit. My sats are probably 50%. So you really need to make sure it's normal blood pressure and expected saturation. So looking at factors such as sympathetic stimulation, acidosis, hypothermia, negative intrathoracic pressure. Same with pulmonary blood flow. This is what we in anesthesia really play with in these congenital heart kids. So I really try and avoid PEEP if I can, or anything above like the normal of 5 of PEEP. They just don't tolerate it. Hypocapnia will decrease PVR. Adequate anesthesia promotes blood flow to the pulmonary circuit and high FiO2. So I can really affect things in how that these patients receive pulmonary blood flow. Factors that increase PVR, PEEP, low FiO2, pain, agitation, and hypercapnia. So when I have a patient that is cyanotic but has a lot of blood pressure, I will turn up my oxygen and increase my ventilation, and it quickly changes in these kids, like these Norwood patients, or in these babies with plumbing that isn't hooked up quite right. So pulmonary hypertension is the worst, as we all know. It is an acquired complication from congenital heart disease from these left to right shunts, causes increased morbidity and mortality. It is usually from increased pulmonary blood flow leading to vascular injury. And then you get just the cascade of increased intimal proliferation and the end result of pulmonary vasoconstriction. It's reversible early in the phases, but it is not in the end. And unfortunately, it may prevent that complete repair of that VSD that we were talking about. If the pulmonary pressures are so high, if you close the VSD, that right heart is just not built to pump against those pressures, and it'll fail if you close it. 15 to 30% of the CHD population is thought to develop at least transient pulmonary hypertension. It's hard to know when that point is of when it is irreversible. Frequently, these patients should have had a heart cath where they will do something called a nitric challenge on them. They will challenge them with oxygen. They will challenge them with nitric oxide, and they will measure PA pressures before and after. And please look at those numbers. Those numbers matter because that tells you if they throw the kitchen sink of medications at those patients, their pulmonary hypertension should get significantly better. Unfortunately, if they don't, there's nothing we can do at that point besides heart-lung transplant. Changes in the vascular endothelium can be observed as early as within 2 months. So the degree of pulmonary hypertension is oftentimes the limiting factor of the patient to be a solid organ transplant. So that's what's so devastating, because a lot of people are okay getting the heart transplant, but the comorbidities involved with heart-lung, as that's a topic beyond this talk, it's a lung transplant is a lot, and sometimes parents don't want to do it. And ultimately, the end result is Eisenmenger syndrome, which is irreversible. It's very poorly tolerated and usually doesn't, as a poor prognosis, leading to cyanosis, fatigue, limited functional capacity, and your only option is the heart-lung transplant. Long-term sequelae, stroke, dysrhythmias, heart failure, renal hepatic function. Thrombosis is very high in these patients, mainly because your pulmonary blood flow isn't from a pumpable or a pumping ventricle, it is from passive flow. And anytime there's sluggish blood flow, there's clots, as well as polycythemia and the consequences of that. And finally, infective endocarditis prophylaxis. Please, when in doubt, just give it. I've never regretted giving ANSEF in my life to these patients. But just to quickly review, cardiac transplant patients with valvulopathy, any patient with congenital heart disease that is unrepaired or completely repaired with a patch within 6 months, repaired congenital heart disease with residual defects at or near the patch, and previous infective endocarditis, prosthetic cardiac valve or conduit, give them to all. And what my institution uses is 50 milligrams per kilo of ANSEF. It's just easy to remember because we give ANSEF all the time. SBE prophylaxis on procedure is dental, pretty much any dental procedure, airway procedure, a procedure involving the soft tissue procedure involving infected skin or soft tissues or the GI tract, and it is, please note that it is not recommended for routine colonoscopy or GI. Thank you.
Thank you so much, Dr. Beathy. We'll now begin our Q&A portion of the lecture. If you have any questions for Dr. Seitz, Dr. Duncan-Wiebe, and Dr. Beathy, please raise your hand and we'll have a microphone brought to you so that you can ask some questions. We appreciate you being part of the pediatrics section because, well, that's what we love until the end of time. Pediatric physiological considerations do go into adulthood, as said, but you can translate things we do in pediatrics to adults, but you can't translate them back, unfortunately. And so we appreciate being able to share these excellent considerations with you. Does somebody in the audience want to ask a question of our esteemed? Yes, Dr. Samaya.
So I'm a peds anesthesiologist at a children's hospital in Corpus Christi, and our obesity is through the roof. I mean, it's probably some of the highest in the country. Do you have conversations with the parents early on when you start noticing that obesity is kind of developing, and how do you have those conversations with them?
Yeah, I think that's a great question. I guess the concern is that you're meeting a patient and their parent at a very vulnerable time. So they're scheduled for surgery. They may be anxious and nervous and not receptive to the information that you feel will benefit them. But if I see a patient or a parent who is calm, and I do believe that they will take the information to heart and be receptive to it, and it won't add to their anxiety or trauma of their day, I actually do bring it up. And the times that I've brought it up, I haven't regretted it. I think it's just knowing when the right time or when is not the right time to bring it up.
How do you approach it when you're wanting to give some ideas and guidance?
You know, I think, interestingly enough, I think when you see a patient who is very clearly obese to you, I think sometimes parents and patients don't really see it as a problem, because obesity is actually a problem within a family. And so a parent may not think that their child is obese when very clearly they have a BMI greater than the 95th percentile, because everyone around them is obese. And so I think just by saying, you know, this is your BMI percentile, which means this, and I want to see you live a healthy life. So if you can talk to your primary care doctor or pediatrician on how to make those changes, I think it will benefit you in the long run.
Love that. Any other questions from the audience? Please raise your hand. Dr. Rose.
Yes, Walt Rose. I do cardiac, peds cardiac at Norton Children's in Louisville. I was just curious, just what cases of congenital heart patients do your generalists do in your pediatric practice?
So we have a list that both our general and our cardiac people agreed to. So for us, anything, and obviously there's variations in this. So anything above 2/3 systemic pulmonary hypertension is done by cardiac. Any Glenn is done by cardiac. Fontan is done by cardiac. Obviously, any cyanotic patient is done by cardiac. So, and pretty much for valvular lesions, it has to be severe to qualify for cardiac. And then, as far as cardiomyopathy patients, I believe it's 30%, an EF of 30%, then will qualify you for cardiac. With the growing patient population, we've really had to get creative of how to take care of the cardiac patients for non-cardiac surgery. So we have we call it the JV team, and they are awesome, and they are willing to take care of some of these patients for non-cardiac anesthesia, and it's really been a blessing to us to try and debulk some of the workload for like the dental procedures, the GI, the MRI, things like that, and that's really been awesome. Dr. Geller does a lot of those for us as well, just because as this patient population grows and the disparity of pediatric cardiac anesthesiologists, I don't really know how the numbers are going to shake out as far as how everybody's going to get taken care of. So we've had to get creative with scheduling and staffing, and thankfully so far it's worked. But with the pediatric anesthesia numbers down for fellowships, and if those numbers are down, there's even less peds cardiac. It's going to be interesting.
I'll add to that while we discussed with our cardiothoracic surgeons and our interventional cardiologists, we made sure that we were the ones that screened and determined whether it was for a cardiac or a generalist to do, because otherwise they default that every single patient that has any congenital heart disease has to be taken care of by a cardiac anesthesiologist. So we carefully curated that. Raise your hand if you have another question. I have some questions for our awesome speakers. There's a lot of good segues between the different topics, but I'll start with Dr. Seitz. When you touched on multimodal analgesia when a bariatric surgery is being done, and knowing that decreasing opiates in the perioperative period for bariatric surgery of any patients of any age continues to be a priority of opioid-sparing techniques. What regional techniques tend to be possible or are utilized in that population?
So at our institution, our surgeons perform laparoscopically guided tap blocks during the surgery. If they remove the trocars and have forgotten to perform them, they inject local at the incision sites. I will say that pain is generally not too big of an issue for these patients postoperatively. It's more so nausea, vomiting. So our patients go home on postoperative day 1 or day 2, and they do not go home with any opioids from our surgeons.
Do you prepare them that it ends up being nausea over pain, and that it's typical, like having your gallbladder out probably it has more pain associated with it? Or
so generally what I say to patients is that you are having surgery, so you are expected to have pain, and really just try and manage their expectations, and that no pain is not reasonable, but unbearable pain is also not reasonable. And so we have to meet somewhere in the middle. And generally the patients that we do this surgery on are just excited to have this surgery and have been waiting a long time to have this surgery. So they're very receptive to that information and think of it, they frame it more as a positive experience rather than looking at the negatives, such as pain is going to be an issue, nausea, vomiting is going to be an issue. Really, they're thinking about is, I can lose weight, I can live a better life, I can not be made fun of by my peers, and things like that.
Love that. Do you use an enhanced recovery type collaborative protocol for giving carbohydrate-containing fluids, etc.?
So I do know that most institutions do that. At our institution, our surgeons aren't, they feel as though they would prefer to have an emptier stomach when they perform the surgery, so they do not do this carbohydrate loading prior to surgery. They also allow us to be a little bit more liberal with our volume resuscitation. So we do follow the ERAS protocol with the exception of the carbohydrate loading prior to surgery.
Thank you so much. Continue to raise your hand if you have a question, as I have some others. Dr. Beathy, as we're looking at all of these different lesions and as these patients grow into adulthood, and some of our esteemed colleagues may be in remote areas or in practices where they may not see congenital heart very often, if they may be faced with a patient that might have a Fontan or tetralogy of Fallot or some kind of palliated lesion, what would be your best advice for induction agents, oxygen settings, nitrous pressors, or meds that you favor or avoid?
On a propofol of anybody in this room. I don't use propofol hardly ever on these kids. They just don't tolerate it. So Fontans are very, very sensitive to propofol. So if you think you can do an inhalation induction, they do tolerate that very well. And if you aren't comfortable with inhalation induction, if it's a bigger patient like a teenager, it's usually a heavy dose of Versed and fentanyl, followed by some type of, whether it's etomidate or low dose propofol chased with some low dose of epi to give it a kick in the shorts. But propofol is definitely should be used with very much caution in these patients.
Do you favor providing relaxation and maybe less volatile during a case?
Yeah, and I frequently warn about recall in these patients because they do have to ultimately earn their anesthetic. My goal is to, and another thing I very much have learned that it's not a failure to run a low dose epi during a procedure to give them adequate anesthesia. So I do warn of recall, and I am heavy paralytic user to avoid the hypotension and everything that comes with it. But I'm also not shy to just start a little epi during anesthesia. This heart is not normal, and it's not a failure of my anesthesia plan if they need a little bit of epi to get them through the procedure.
Thank you. I actually have a question for Dr. Duncan Wiebe. What are some ways that you or strategies you use to pre-medicate a large teen with that happens to have autism spectrum disorder to get them to the OR? You did describe one of your strategies that was really clever, where an inhalation induction may not be typical, and let's say that they are larger. I guess what pre-meds or combinations or routes do you find to be an effective approach?
First of all, we like to make sure children take their morning behavioral medications with a clear liquid prior to coming to the hospital the day of surgery. If they've had any experience with a benzodiazepine at home, a lot of these kids will have like a PRN medication that their primary can provide. That's helpful, even just to get them in the door often. Other pre-medications, there's always IM ketamine, intranasal Precedex. We do tend to go with a much higher max dose of oral Versed if the parents can help the child take that. I've gone up to 15 or 20 milligrams of oral Versed. In normal kids, I'll stop at 10. Those are kind of our most common pre-medications. Other things that I have done that are kind of outside the box, I've done inductions in the hallway with like 4 circuit extensions on a 300 pound kid that was like really stressed out by enclosed rooms, and our dental procedure rooms were quite small. So we did the induction in the hallway. Thankfully, I had 2 CRNAs with me. So you really have to think of what the kid will tolerate and how you can like make the environment in a situation that would be acceptable. The other thing, in our hospital, we typically don't bring parents for induction. I think autistic kids are sometimes the exception to this. You really have to do a quick assessment of the parents and see if one of them would be helpful to you. Sometimes they're not, but often a parent that really can control their child is also like the best pre-medication. So
I think that Dr. Duncan-Wiebe clearly demonstrates being able to say, I can't use the same cookie cutter approach to everybody, because we're customizing the approach so that especially patients that may need to have repeat procedures and it becomes really traumatic to them to have to engage in this way. If they have a good experience and they continue to have good experiences as it's been customized, they actually have better experiences subsequent to that. And so going that extra mile really does have great payoff for those patients too. Do you agree, Dr. Duncan-Wiebe? Any additional questions that we have in the audience for our esteemed speakers on these topics? Okay. Thank you everyone for your questions. We are now at a time where we need to conclude the session, which is actually early, which is nice. So we would like you to join us in thanking Dr. Victoria Sates, Dr. Greta Duncan-Wiebe, and Dr. Amy Beathy for their excellent lectures.